All right, so I see that we're live now. Great to have everyone here. Thank you. We're here now talking with Dr. Craig Tanio. Welcome, Craig. Great to have you here, Craig. We've got. I should mention, Craig was one of the six clinicians. He is down in Hollywood, Florida. Has an absolutely fantastic clinic, Resilier Clinic. And the idea was we talked to Anne Hathaway and Kat Toops, and we'll be doing questions and answers with them next week. Craig had some changes he made. He did the basics that others did, and then he made some changes that he'll talk to you about today, with some very exciting results. And so we're all interested in the same thing. How do we get best outcomes, and how do we continue to make progress? So before we start, let me just share one thing. I want to show, if I could, one image, which is interesting because in here, let's see, here it is. Okay, so this is arterial spin labeling, and you can see this is a person who went on the protocol. They were not part of this trial, but it was a person who went on the protocol, was seen at Pacific Neuroscience Institute by Dr. David Merrill, and also by Dr. Rachel Husner and Heather Sanderson. You can see here in 2024, the red is high blood flow, the green is lower, and the blue is lower still. And you can see the abnormalities that are characteristic of Alzheimer's. This is in an ApoE4/4 individual. This green here, right in this area, indicates that the precuneus region is too low. And then you can see here a year later, it's absolutely completely normal. So these are the sorts of things that we're very, very interested in documenting, situations where we can actually see striking differences. So, Craig, if you could talk a little bit about the background, how you set this up, what you did similarly in your clinic, and what you did differently in your clinic during the randomized controlled trial.
Sure. Thanks, Dale. First of all, thanks for having me here. It's great to really be a part of this, and it was terrific to be a part of the whole Evanthea team. Really proud of the results that we've accomplished. And if I step back, I would just say that, I think the major impact of the study for me is a couple points. One is precision medicine works for cognitive decline, period, end of story.
Yeah.
Number two is it does look like fixing the brain requires that we need to fix the body. And so we need to take what I like to call an expert generalist approach. You have to
Yeah.
be a generalist to understand all of the different systems that are required to fix the brain, but then you have to be an expert in understanding how the body-brain connections are really working. The third point, I think, is that multiple intervention approaches should fast become the standard of care for cognitive decline because of this type of research and in the context of other research. And that the research budget in multi-intervention approaches needs to increase by at least 10x for us to really get the progress that we want so that Alzheimer's can be a rare condition 10 years from now, And so those are the points I take from the study. My expertise had really been as, in addition to being a practicing physician, I'm not a molecular biologist like yourself, but rather, I had been an expert on how to create health systems and processes to fix complex chronic disease and to get superior outcomes. Because the challenge healthcare faced in the past was to just even get blood pressure fixed, which is a relatively simple task. Kaiser in 1990 was getting only, 50% of patients with blood pressure better. And when we take a precision medicine approach where we're trying to fix multiple things, the big challenge is how do we do it in the right way? So what we did as part of the study, I'll kind of divide it into what we did in the study and really focus on that, but I'll give some context about how we got there. In part of the study, we tried to sequence things where in the beginning of the study, we really focused on getting all of the life essentials right, food, movement, sleep, stress, all of the different parts of the protocol that were very clearly delineated in the protocol documents. We tried to get that going with a goal to really have most patients, have that on board and have significant improvements within the first 4 to 6 weeks while we were getting testing. Then we tried to address a lot of the micronutrient and hormone issues, saving the addressment of chronic infections and detox, usually for months, let's say 3 to 6, in the middle. And then from month 6 to 9, we emphasized what we're calling intensive neuromodulatory therapy, which was to try to add some additional interventions such as hyperbaric oxygen at 2.0 atmospheres, trying to
Mhm.
use photobiomodulation through a cold laser from Aspen, and then doing neurofeedback, and then finally using the QEEG as a way of monitoring change. And we kind of came to this as we have been doing this protocol with you since 8.5 years, and we would have a number of patients come to us in South Florida saying, I've tried the protocol, I've done a number of the dietary changes, I've not had as much improvement. And they would often come in with a MoCA of less than 16 and have a lot of atrophy. And then in those conditions, as you've said before, it's harder to get as much of improvement in getting people all the way back. So, a number of these, we looked at a lot of these therapies, and we tried to evolve into a center where you could have all of these therapies under one roof to make it easy for people. But then the question is, if people are paying out of pocket, when you
Mhm.
sign up for 60 hyperbarics, patients naturally want to know, is it
Yeah,
working after 10 sessions? Is it working after 20 sessions? And so you can get that the first image was like a PET scan, right? Was that you showed?
that was
Yeah. So
actually an MRI with arterial spin labeling. So it
even,
essentially
mhm,
mimics
yeah.
a PET
Uh-huh.
scan, but with
Yeah.
much better resolution.
Yeah, even better. So there's a lot of functional testing that there's a lot of new research in there, and with really high quality. The challenge really is the cost, and so we've
Right.
evolved to the QEEG, which can be done at the bedside in the clinic for really a low marginal cost. And I'm very thankful to Dr. William Lambos, who's a psychologist who really mentored me in this for about 2 years to get board certified in QEEG and neurofeedback. But once you start using these functional tests, it's like having a stethoscope on the brain,
Yeah.
and you can see the changes of interventions. And once you go there, it's really hard to go back because the
Right.
EEG is a very rapidly changing test. And it really answers some of the questions of, are you tracking in the right direction or not?
Yeah.
And so we tried to do that extra level of personalization. But we found in our experience before the study that the foundations, this is just part of precision medicine. It has to be kind of folded into the overall precision medicine protocol for it to work.
Right. Right. So, and I know you've got a nice image of the EEG. You want to show that?
Yeah, so maybe I could just share a case,
Yeah,
of
that would
someone
be
we
great.
saw in the study. So a sample case. This was a woman who was 67. She was ApoE33. She grew up in South America for the first 25 years. She had a sister who had Alzheimer's in her early 70s, and obviously she didn't want that to happen. So was very motivated, had come in with about 5 years of symptoms. It had started a little bit pre-COVID, but accelerated during COVID. And
Yeah.
then during the last year, she was not on estrogen replacement and had been working on diet, had read your book. And like
Mhm.
many people who came in the study, they were aware of a number of the changes, but hadn't fully implemented
Right.
them. So she met criteria. The evaluation for her really showed issues with toxicants. She's had exposure to mold with Hertz Me 2 of 20.
Mm.
Not surprising in South Florida. She had
Yeah.
elevation of mercury and a number of other chemicals, high oxidative stress, high C4A and TGF beta, high amount of chronic infections, particularly viruses as well as toxo. And then with the vascular side, pretty interesting that she had high COVID spike antibodies, high fibrinogen products, a lot of small vessel ischemic changes, but really a
Mm,
negative calcium score and the low atheroma volume on a clearly test that she had gotten for other purposes.
right.
Really had a lot of lymphedema, metabolic syndrome, problems with the microbiome, and then some elevated thyroid antibodies, low
Mm,
B12 and low hormones. So within the root causes,
yeah.
of your 40s, you probably check 20 of them,
Yeah. Yeah.
if you
Which
will.
is common. Yeah.
So
We get all
yeah.
these different ones contributing. Yeah.
Yeah, and so it was very adherent to the protocol. Really did a great work. Really followed the all of the changes in food and sleep and exercise. I think the bioidentical hormones really worked quite well. By month 4, she had her environmental remediation done, which was always a challenge in Florida. And she did a good detoxification protocol, and she had careful treatment of her viruses and microbiome. And the interesting thing is that she had had lymphedema. We worked on improving her microcirculation and infections. And one of the things that she was happiest about is her lymphedema resolved. She could see her ankles again after four
Yeah.
years, and was like no other doctor has been, able to do that. And that's one of the positive effects of the study that we see is that people just get healthier. So in her case, her MoCA improved from 22 to 27. Her CNS vitals, the neurocognitive index, improved from about 64 to 108, which is an improvement of about 2 standard deviations, or maybe, about
Huge.
60 percentile improvement.
Yeah.
And I'll just give an example on the EEG of how these changes kind of look like. So let me make sure I do this right with sharing. Okay, there it is. Are you,
Okay.
are you able to see my
There it
screen
is.
here?
It's
Okay.
coming up now. Yeah.
Yeah. Okay. So
There it is.
this
Okay, good.
so the screen is sort of in here is so the way to look at these is that we usually get in the EEG 30 little cartoon heads, and there's a nose, and there's a left ear, and there's a right ear. And the brain works at different cycles. And so this 1 hertz stands for 1 cycle a second. It goes all the way up to 30 cycles. And the way the maps work is the red means there's higher activity than normal, and the dark blue means there's lower activity than normal. And this category, 1 to 5 hertz, is called delta. It's usually most active when you're in deep sleep. The
Yeah.
next one is theta, which is more relaxation. Alpha is meditative concentration. And then 16 and above is beta, which a lot of the cognitive activity is in there. And what we could see is that what we see in many of our patients with cognitive impairment and early Alzheimer's is they have increased delta and theta,
Yeah.
usually consistent with an energy deficit. And we could see this was her baseline. And as a number of the metabolic conditions improved, her brain was basically getting increased energy, if you will. And there's more subtle things on the EEG that we can look at. We can actually map some of the networks. There's an ability to actually look at those networks like an MRI. But this is just, I think, an example of how the EEG can show us that we're going in the right direction. I think it's very complementary to other things. The real benefit can be that if you see a patient at 12 o'clock, you can see the EEG by 1:30, if you will, without having to send them away. So it just gets the results pretty quickly.
Yeah, that's really nice to have. You have it right there. I know some people in the past, in setting up various electrophysiological setups like Evoke and others, have complained that, oh, it's difficult to get this all set up for each patient. Have you found this to be a problem? And how long does it typically take your clinic to set up to do this? If someone comes in at noon, when would they have this on?
The EEG itself Usually takes about 30 minutes, maybe max 40 minutes
Okay.
to do. Uh, Usually, if somebody's done it more than once, then that time gets cut down in half because
Right.
there's a little bit of getting used to
Mhm.
just getting the cap on and the gel. The biggest complaints people have are the gel and having a little bit of a bad hair day with extra gel, unless you use gel. And but it works pretty well. I mean, we have an outstanding technician named Millie Snyder who's done a great job, and we get I'm certified in it, so I'm able to read the EEGs, fairly quickly here. There are definitely some other EEG companies where it'll get centralized and read, but you know, it's a bit like learning how to use pocket ultrasound. Is it
Right.
used to be in the hands of echo techs and such, and now pocket ultrasounds are done by most primary care physicians. So.
Yeah, fantastic. Okay, so I think it's important to point out you basically made this not a monophasic approach, a multiphasic approach. You start, as you mentioned, the first 3 months, then the next 3 months, and then you're adding things. And I do think it's important in terms of what comes first, because, just like if you're going to be a weightlifter, you better not start out malnourished. You better nourish yourself first and then start lifting the weights. And that's kind of what you were doing here. You're getting them up to speed, you're supporting the brain, then you're adding stimulation like the laser, and
Mhm.
you're adding HBOT, which is now getting presumably better oxygenation throughout the brain. And certainly, of course, there are published trials like from Aviv showing that you can get some improvement with that alone. Again, better if you're addressing the entire system. So that is really exciting. Maybe you could talk a little bit about what did you see? Now, everybody saw some improvement 3 months, 6 months, 9 months, but you had
Mhm.
an interesting phenomenon where you saw 3 months, 6 months, and then 9 months, you really saw this additional piece. And maybe you
Yeah.
could speak to that.
Yeah, I think what we saw here is that, one of the questions just with precision medicine is going to be we are rapidly, every year you kind of ask yourself what's new in the market,
Yeah,
what's available. And this last year now there's a machine that's doing smell training when you go to sleep at night,
yeah, yeah,
for example. So there's going to be a proliferation of options. The question for us as clinicians is how do we put this together in the way that gets results for patients and is cost effective and easy to do and aligned with their values and preferences. And um, so I think in we wanted to do an additive approach, and then we thought that methodologically, if we waited to the last 3 months, we would be able to see the effect of it. And I think in general in the study, everybody got up to a very fast start with the implementation of the overall protocol. There's usually an improvement of about I think 8 points in the neurocognitive index across the board. The challenge in the next couple months is when you add things. The challenge in the study is how to do detox and chronic infections right, because in the real world that might take 18 months or
right.
24 months to do. And so within the context of the study, there needed to be some real clinical judgment about improving it, but not taking a step back. And I think a number of people, if there was somebody who took a step back, almost all of them was in the context of detox or infection or,
Yeah,
adherence. And so in the last 3 months, when patients got the intensive neuromodulatory therapy, there was a good improvement of an additional, 5 points in the neurocognitive index,
yeah.
on top of the existing trajectory.
Yeah, that's fantastic. That's very exciting. And, excuse me, as Christine Burke has pointed out before, you tend to get if you do the basics, you'll get an improvement that'll last somewhere 9 to 12 months or so. and I think everyone's observed this. But if you then don't get to the root causes, if they've got continued exposure to mold or continued exposure to other toxins, for example, or continued infections, ultimately it's going to come back down again. But if you address those things, then you can continue. And we do see people not only who have continued their improvement and sustained it for over a decade, we also see people who will, even after a year or two, they're still going up, up, up. Just this morning was talking on a Zoom with Sally, who's now in her ninth year,
Hmm.
and she's continuing still to get improvement. She's now up at the 87th percentile for people her age, for all people her age, not people with Alzheimer's, everybody
Yeah.
her age, and doing exceedingly well. And then I would say a complementary piece to this is the people that you had in the control group. You were observing that they were going down, but then after 9 months, they were offered the opportunity now to switch over to treatment, to the precision medicine treatment, and you saw some very exciting results.
Yeah.
And I don't know if you've got it right there in front of you, or I'm happy to share it, whatever's good for you.
I think you have it, so that if you could show it, that would be good.
All right, yeah, let me pull this up and you can talk a little bit about what you saw here. And let's see here. Let me go back to, let's see, here we go. Share. Yeah, here we go. So let's bring this up. And here. So here, these are data from your site. And maybe
Mhm.
you could talk a little bit about what you saw here.
Yeah, so I think the first thing to talk about is, what happened to Group B who got standard of care. And I think the hardest thing methodologically in the study was to tell people this is a study that can improve your health. You need to be motivated to change. You need to be willing to treat it as a part-time job, for you to get success, and you need to be ready to go. Now we're going to flip a coin, and there's a one-third chance that you get told you need to wait for 9 months. That's tough
Right.
on
Yeah, it is.
somebody
Yeah.
psychologically. And and one of the challenges was do people cheat or not during that time? Because you don't have the controls to prevent it. Um, I would say that our the people who were under the standard of care did have decline, and a number of them went down significantly during this time, and that was a pretty scary time because what we were doing is just making sure that they're adhering to their existing protocol. So you saw a number of people, really reduce their scores, significantly by the time that they were eligible for 6 months of treatment. And what we did on here is, because we only had one outcome, we didn't necessarily save all of the treatments in the back end. They started more in, let's call it, maybe month 11 through 15, rather, because we only had 6 months instead of three
Right.
months. So we just
Right.
kind of had a squeezed in protocol, but people did get the full amount of intensive neuromodulatory therapy. And as you can see, there was through all three uh, um, patients that they all had significant improvement uh, in both their neurocognitive index, their composite memory, and the executive function. And these were, quite considerable and life-changing. And I think because we developed this in patients who had MoCAs less than 16, I think one of our patients, for example, went to a MoCA of 11. She started at a MoCA of 19 and went down to 11. She was able to, bounce back up significantly. We were prepared to move this along in a very, accelerated manner.
Fantastic. And I know in St. Augustine, Florida, you introduced me to one of the subjects who's been a real activist and really
Mhm.
an amazing guy who unfortunately randomized into the control treatment and then had some problems during that time. And if you could maybe just tell a little bit about his case, it was a very interesting one.
Yeah, no, he definitely he was young which
Hmm.
is an increasing profile in our patient population. It's
Yeah.
unfortunate that Alzheimer's is becoming more of a young person's disease, as you've discussed. Number two, he absolutely had issues with toxicants.
Yeah.
He was in a mobile home, and
Hmm.
mobile homes have real challenges with trying to keep air quality where it needs to be. And
Right.
he had a number of different infections that were causing an issue, and including recurrent COVID. And so we
Mm.
really did work through these issues. He did get hyperbarics, within 2 months of being on in the protocol, and really had a nice level of improvement, which he's been able to sustain, now
Yeah.
for a good almost a year since the he's out of the protocol. So,
Yeah. That
or
is just
out of the
fantastic.
study, he's continued the protocol. Yes.
Yeah, and as I recall, one of the points about him was he had actually been to other places before and really hadn't had any help. And so he really had, this wasn't something new. He had several years of symptoms before he came to you,
Yeah.
thankfully.
Yeah.
And then you really turned things around for him, which was fantastic.
Yeah, yeah, no, we see this all the time where I think that the challenge here is really kind of getting different definitions of health, because people
Yeah,
will see neurologists all the time. I see it in my younger patients with chronic fatigue where they're having cognitive issues. They're not doing well in school, but the neurologist is like, look, you're scoring above the 50th percentile, but it's like these people had an IQ of 140 before and
yeah,
were
yeah,
crushing tests in their sleep, and now they're struggling.
yeah.
And I think those same principles apply, which is, we try to get people metabolically and systemically healthy.
Yeah. And as we all pointed out on the preprint, the systolic blood pressure showed a statistically significant improvement. Diastolic blood pressure showed a statistically significant improvement. BMI, body mass index, showed a statistically significant improvement. Lipid profiles, improvement there. Insulin sensitivity, improvement there. So, as you said earlier, this is very much a systemic change that is impacting the brain. So all these things improve. And I think that there's a really important point here. David Perlmutter has just posted the discussion about whether Alzheimer's should be diagnosed in people who are asymptomatic but have abnormal biomarkers. And it's being pushed now by pharma because, of course, they would like to put you on these very expensive
Yeah.
drugs that are ripping the amyloid out of your
Mhm.
blood vessels, unfortunately, and have horrible side effects. Well, if you've got something that doesn't have horrible side effects and only has good side effects to improve your blood pressure and improve your insulin sensitivity, then it actually makes some sense to start
Yeah.
if your biomarkers are abnormal and you're asymptomatic, no problem. You get on something that's going to reduce your risk. And I think the take home there was yes, there's a difference between being completely asymptomatic, doing well, and having abnormal biomarkers. That really says your risk is high. Whereas once you've got SCI, MCI, or dementia, now it says you have the underlying pathology and you either have Alzheimer's with dementia or you're headed in that direction likely. The great news,
Mhm.
if you've got something that's helping people across the board, you don't need to worry about whether it's early SCI or whether it's pre-symptomatic or what it is. Do the right things. You're going to reduce your risk. You're going to improve your cognition overall.
No, you're absolutely right. I mean, the critical piece that almost all health systems deal with is all of the costs in healthcare from chronic disease. And if you look at the top three, diabetes, atherosclerosis, neurodegenerative, all of these can be improved and put into remission or reversal
Yeah.
through this type of precision medicine approach. So, and I've been teaching residents and medical students for, 20 plus years. I ask people all the time, how many times have you seen a case, of significant chronic disease reversed? There's
Mhm.
very few hands that go up. And so the gap between what can be done with the knowledge that we have and what's being done is enormous. And
Yeah.
that has to change.
Is a great point, and I think you're the one. I mean, everyone who was on this trial has very complementary skill sets.
Hmm.
And for example, Kat Toops is the one who's done the most trials herself. So we've got
Hmm.
everybody on there has got a different expertise. You are the one who's the best positioned to take this from new observation and trials to public health. You are a
Hmm.
public health expert, so that
Hmm.
you can really make this part of public health, which is what needs to happen for people to be able to do this. So let's take some of the questions here, and we can continue the discussion. As part of the answers to the questions. There's some excellent questions coming up here. Jennifer's asking, how long should someone be in ketosis per day? I mean, what we've recommended and what Julie G has actually recommended in the past, which I think is a good idea. If you can get over 1.0 millimolar beta hydroxybutyrate once per day when you're treating your cognitive decline, you're usually in pretty good shape. But yes, if you can go a little longer. Now, there's a big caveat here. Be careful for people who are frail when they start. You have to be careful about having too much fasting because you can actually go backward instead of forward. For people who have higher BMIs over 25, and you've got some lipid to burn, great. Then you're going to do much better. Craig, what do you recommend for people as far as how long to be in ketosis each day?
No, the same that you recommended. I think the key is, I think in the beginning, there's a set of people who can take a step back pretty quickly when they have, let's say, gut issues or really high toxic burden. And in those, I think you have to be pretty careful about getting them into ketosis, or if they
Yeah,
lose a lot of weight pretty quickly. And
right.
so I think that if we don't see that, then I think exactly what you've been saying, it makes a ton of sense.
Yeah. Next one here is from Caroline, who says, does this protocol also work for late, which is the limbic associated TDP, age-related TDP-43 encephalopathy? So this is one that just described a few years ago. It's actually relatively common, and it's mostly people in their 80s and 90s, which is one of the reasons it's called late. One of the
Mhm.
tip-offs is you see some atrophy in the amygdala. So if you've done volumetrics, check out the amygdala and see if there's some atrophy there. That's a tip-off. If the person's in their 80s or 90s, that's another tip off. So
Mhm.
again, what we're changing here is the old idea was it's all about pathology. Oh, look, you have amyloid in your brain. That's bad. Let's get rid of the amyloid. What we now understand is not from the pathological side, but just what Craig's been talking about. It's the physiological side. What are you responding to? So we now know that as we're now defining these, amyloid tends to be made to kill certain microbes, such as herpes simplex, one of the big ones, and some of the spirochetes, for example, and Candida is another one that is killed by the amyloid. P-tau is a different antimicrobial protein. So these things are turning out to be part of your innate immune system. And I believe that they are a pre-inflammatory component of the innate system because you can go for years, as long as you don't have inflammation, with amyloid in your brain with no cognitive problem. Once you get the inflammation coming in, that's a problem. Now, so having said that, what is late? Late is instead of responding with amyloid or with alpha synuclein or with tau, you're responding with TDP-43. Well, what is that? That is an antiviral response. So it's likely that we're ultimately going to see that people who have late have had exposures to specific viruses, things like COVID potentially. And so we don't yet know. We don't have enough data to know whether that will respond to the approach we're taking. My guess is it will, in that we are taking and looking at what's actually driving these. So you should be able to figure out what viruses are there, address those. And as we've talked about, you're going to be in better health. Your immune system's going to be in better shape anyway. And I should add, TDP-43, this late, tends to be slower decline than Alzheimer's disease. So that's a positive. So
Mhm.
we look for more data on this. And we did have a number of people in the trial who did not have classic Alzheimer's but had cognitive decline. Some of those may turn out to have late. Craig, what about in your clinic when you see people who have a non-Alzheimer related cognitive decline? Have you had good success?
Yeah, so I think that there's there's an evolving view, I think, from the network. I think one of the challenges here is as an individual doctor, you have, a certain volume and you certainly want to get insight from the colleagues. And so, the brain board that you've put together is a good sounding board for that. It does look like that Lewy body has a good response to this type of protocol. We always think with Lewy body, we need to do more, treatment of toxicants because the association with synuclein and toxicants is pretty well established. There's a good response on the vascular side. I think we've seen certainly with some variants like cortical basal syndrome that treating toxicants can help, and we wrote a joint case study on that together.
Right.
The frontotemporal, I think, is the most challenging,
Right.
where that just doesn't seem to have the same level of response. And what does seem to happen is, a number of the patients I've had with that seem to get these chronic infections that their body just cannot,
Right.
respond to as effectively, and that there's definitely, more effective therapy needed.
Yeah, great point. And you bring up a good point with the corticobasal degeneration that you saw. That's a
Mhm.
relatively uncommon presentation, but is about 20% of those cases turn out to have Alzheimer's, as your patient did. And she
Mhm.
responded beautifully to
Mhm.
your treatment of her with this sort of
Mhm.
precision medicine approach. As you mentioned, she had a lot of exposure to toxins. And interestingly, she, as well as so many others, was told, nothing can be done because there hadn't been a case of corticobasal degeneration showing improvement. Recently, there's another one from another person who has shown improvement in PSP, progressive supranuclear palsy, which is a tau-related, non-amyloid related.
Mhm.
Again, I'm not aware of anybody with PSP who's gotten better before. So we're seeing these single cases again and again and again, and documenting the improvement. Which is wonderful to see. Next one here is also from Caroline saying, how was Dr. Tanio able to get specialized MRIs? Other doctors weren't able to order them or aren't able to order them. And I think she may be referring to the one I showed at the beginning, which is arterial spin labeling. That person was not in this trial. That person
Mhm.
was seen, and I have to give credit, Dr. Cyrus Raji, the neuroradiologist, was the one who originally suggested ASL as a good way, and it's turned out to be fantastic. I gather it's being done just starting
Mhm.
at Cornell. So I think we're going to see a lot more of this over the years, just as we've seen a lot more volumetrics in the last decade. We're going to see a lot more ASL in the coming decade
Mhm.
because it is so effective. So you can get it at a couple of places, including Pacific Neuroscience Institute, including Cornell now, as I mentioned. I think you're going to see more and more. It's very sensitive, and it's a good one to follow improvements in these
Mhm.
people. But in the trial, we had standard volumetric MRIs. Next
Mhm.
one here is saying, did you do PET scans to determine if there was a reduction in amyloid beta? No, there were no PET scans done in this particular study. Others have done these and shown with the same sort of approach, reductions in the amyloid. Also, that tends not to be a very sensitive way to do it. The electrophysiology that Dr. Tanio showed is actually a much more sensitive way to look at this.
Mhm. Yeah.
Next
Is
one.
it essential
Good.
to sleep for an EEG? The answer is no. You don't need to sleep for an EEG. No.
Great. And then there's one here from Deborah's asking about what about the protective variants? And frankly, I'll have to check with with Intellex DNA and 3x4 to see if they're running these. I know that there are other groups that are running these, but they aren't running the things that are important for functional medicine and precision medicine. They're not running all the things related to methylation
Yeah.
and taking care of the patient. So of course we want to have both.
Yeah. Can I answer the next one around
Please, yeah, yeah, yeah. Go ahead from
why
Dr. Kogan.
placebo? Yeah, why placebo did so well in the trial. I think is a really critical question, and context is critical. In studies where there is a lifestyle or wellness component, and you're selecting for people who are motivated and willing to do a number of those changes, almost in all of those studies, the placebo group does improve. And so that's just the background. On the mocha, we do think that there was a learning effect on the mocha, given that the mocha was done 0, 3, 6, 9 months, which does not, there's not a learning effect on the CNS vitals. And so the CNS vitals, I think, is a much better way of testing cognition. But we did both.
Yeah, and it should be pointed out, they did not improve their cognition on the
Mhm,
CNS vital signs.
mhm.
So this is a more sensitive, more rigorous testing. MoCA is, quick and simple, but it is not as rigorous as the CNS vital signs approach. And so they actually declined, as you saw earlier, on all three. They declined on the overall cognitive score. They declined on the memory scores. They declined to a lesser extent. They declined on the executive. In fact, the executive by the end was almost no change. But in all those cases, there was a improvement in the treatment group. Now the MoCA was a little different. They did show some improvement. It was not as much as in the treated group, and in fact, the difference was not quite statistically significant at 0.154. So it was a trend that did not reach significance. Now, to be fair, a few of those people either found things during, for example, Dr. Toops had one who turned out to have sleep apnea and B12 deficiency that were both treated and then improved. That was in the control group. Another one, it turned out, unbeknownst to her, was getting repeated checks of her MoCA every few weeks at a university, and she didn't even know this. So, of course, the person was just getting better and better and better simply at being able to do a MoCA. So there were some issues there. And of course, as Dr. Tanio alluded to, there are many people where they say they're going to be part of the control group, but then they rush off. And of course, they're understandably, they want to do the best for their own brains. And so they start doing as much as they can outside the study. And so, of course, they can often show some improvements.
And
So,
the critical part of the control group is to show what's going to happen and that you're able to, with the randomization, kind of control for a number of so things. So the key thing in the study is the difference between the two,
yeah,
which is significant and not only statistically significant, but highly clinically relevant. I mean, a change in standard deviation is 30-40% improvement on the cognitive scores, and that kind of improvement has never been seen in a cognitive decline study before, period.
yes. And in addition to these various tests, we also had a cognitive symptom tracker that actually came from Dr. Burke and was used, and that was very effective. And then we also had the AQ20, where you're asking the partners to say, do you see improvement? Do you see decline? Because some of the tests in the past and some of the trials in the past, the spouses couldn't tell any difference at all. Yeah, there was a tiny, tiny difference that you could look at, but in fact, they couldn't tell the difference. In this case, both of those came out very positively. The partners could tell unequivocally that the people improved and that they declined in the group that was standard of care. And in fact, on the cognitive symptom tracker, they had improved as well. So those all support the same finding, which is that yes, this is going in the right direction. I do
Mhm.
think we are rapidly approaching a time in which standard of care, or at least minimal treatment, which is the current standard of care, is no longer ethical in these sorts of
Mhm.
trials. And the fact of the matter is, there's a tremendous history in many, many publications. So we know what happens to people who are at this stage. And in fact, the stage we used, which was MoCA of 18 and higher, matches up almost exactly with what was done in the drug trials. So this is
Yeah.
MCI and early dementia patients.
Yeah. And that the effect size also in the randomized trial very similar to what was done in the pilot study. So a lot of
Yeah.
times these studies are done once, they're done with enough power to just get the answer done and never repeated. And so now this has been repeated more than once by different investigators and getting similar results. But you could imagine in the future you might have basically the change in the maybe a core protocol that is around food, exercise, movement, stress, some of the basic parts of that, and then compare that, to different additive parts of the protocol. We have to figure out over time what is additive, where there might be synergy, where there might be a threshold function, where there might not be synergy. And that's really, I think, the challenge that we'll face going forward is how do you do good research to figure out how to make it even more effective and then less costly over time.
Yeah. Next one here is saying, is mold a cause of autism? This is a great question. And you go back to the mechanistics that we studied for 30 years in the lab, and you look at this molecule, amyloid precursor protein that sits in the neurons, especially at synapses, and it has this very interesting switch effect. When things are good, you're on the connectivity side, connection side. When things are bad, it flips over to the protection side. You make the amyloid, you make the tau, you change, and you can see it at every level here. So you go from this connection to protection. Now you have the degeneration associated with the amyloid and with loss of synapses. If you look at autism and ADHD, it's as if you took this same process, but you moved it earlier in life where you don't have the degenerative component. And in fact, on the Alzheimer's side, that's the sort of signaling you see in ADHD. The synapses are not quite as tight as you'd like them to be. So, of course, they're running around beating things and they're not great in school. Interestingly, we tried to make a fruit fly model years ago, Alzheimer's, by inserting Alzheimer genes into fruit flies. And they didn't develop Alzheimer's, they developed ADHD by all criteria. They even responded to the treatment, et cetera. Now, interestingly, it's the other side. It's the connectivity side that is associated with autism. They actually have higher SAPP alphas than normal. They have lower A betas than normal. They have higher BDNF than normal. They have higher brain volumes than normal. So those two are almost polar opposites. My suspicion is that you're seeing this in a situation where there's been some damage and you now have a hyperactive response in these people. So you get these amazing people who can remember things, can do all sorts of math, but they don't have some of the other functions that you would normally have. So with all of these, you do have to dig in, just as Dr. Tanio was saying earlier, and look for things like mold and mycotoxins and gut changes. Of course, in autism, gut changes are a huge issue. And I do think that we're going to see more and more of this sort of precision approach to things like ADHD and autism.
Mhm.
And Craig, do you deal with much autism in your clinic?
I'm an adult doctor as opposed to a family physician. So
Yeah.
not the younger ones, usually people who are older than 13. So we have definitely had a few cases of autism come at that age. And we do the same type of approach of looking at root causes. I think the intellects can be very, very useful. And then certainly some of the other pathways like cerebral folate antibodies and folinic acids can be very helpful as well.
Fantastic. And Robin is asking here, Craig, if you can speak to the laser treatment.
Yeah, so on the laser treatment, we use it in a couple of different ways. We'll use the EEG to help us look at particular networks that are dysregulated or particular parts of the brain that really are not working as well. The laser can improve healing. It can absolutely help with mitochondrial energy, and you can sometimes see that direct effect after application of even 2 to 3 treatments. Uh, the laser that we use, the cold laser, does get through the skull and it is quite safe. Has had an outstanding safety record. The challenge on the laser then is having enough. This is like the timing issue before that you said, Dale, which is the light therapy can help, but certainly those changes can be sustained when you've really helped the cellular health the most.
Yeah.
So to answer Robin's question, we used it guided by the EEG, but we were not able to, in the protocol, disaggregate the effect of the laser versus other interventions.
Yeah. And I think this is, this is where AI is going to be, analytical AI is going to be so helpful to us over the years as we get more and more data, more and more combinations. It'll be able to go in and find patterns that you wouldn't find on your own. So again, I think this is going to be another one of the upcoming steps that could be very helpful to make this better. Next question here is about FTD. You mentioned this earlier. That's a challenging one, frontotemporal dementia, much less common than Alzheimer's, but also much more difficult to treat. We don't have nearly as much data on this. I know Dr. Hidea has got some preliminary data on some improvement there. Craig, have you seen much frontotemporal dementia in your clinic?
Um, Probably the lower amount is similar to what its prevalence is in the market, and so it tends to be a lot less common and certainly presenting in younger patients. So.
Yeah. I think when we see people coming in, for example, with primary progressive aphasia, somewhere around 20% of those patients that have the so-called logopenic variant will have Alzheimer's. But many of those, the majority of the ones coming in with primary progressive aphasia will turn out to have frontotemporal dementia. So I think that's a good group to look at and to look to see. Again, you look at FTD, many of these will have either the TDP-43, some of them will have the C9orf72, but they tend to have this TDP-43 response. There are some with tau, but the majority will be more on the TDP side, just as you see with ALS and just as you see with late. So again, this to me suggests initially we need to be looking very carefully at viral infections and what's happening. Is that the response that they're getting? All right, the next one here is from Deborah. She says, is a reason for younger, I assume, presentation here due to PFAS. And certainly, forever chemicals are an issue. People tend to have these overall burdens of multiple different things from the biotoxins. Now, of course, we're seeing more microplastics was another big issue. Craig, do you see many people in your clinic that have these forever chemicals?
I think yes, and I think the big question here is the total toxin burden. Is that most patients that we see who come in with cognitive decline, and you do a good toxicant test, you're having a number of them be positive. I've rarely seen somebody who hasn't. And so it's a real challenge because people are trying to take care of their health, but there's definitely a regulatory component to all the toxicants that we're exposed to. And
Yeah.
what we absolutely need is better research about easier ways to detox. And we certainly almost all of our patients are giving them practical answers around how to detox better.
Yeah. And then Christopher's asking about in Leqembi and infusions. So a couple of things to note. Excuse me. So we have had a number of people, and actually Sally is a good example. Sally years ago had 8 different injections. Typically they're given once a month. And she was on an anti-amyloid trial. And with each of those, she clearly got worse. And the typical thing is you get worse within the first week, and then slowly over the month, you slowly come back almost to where you were. But over multiple times, you tend to sawtooth down. So that can happen. You have to be careful of that. Of course, it does have side effects. They are worse in ApoE4 positives. In the people who are ApoE4 homozygotes, and unfortunately, it's still being recommended in standard clinics for people who are ApoE4 homozygotes, even though the data show it is worse than nothing. It enhances their decline to have the four. So it just kills me that they're still recommending this for people where it's actually worse than nothing.
Well, the FDA has a black box warning on it
Yeah,
now
yeah, it's a
for that category of patients. Yeah.
and yet I hear it every day. They're still being recommended, people who are 4/4s still being recommended to take these infusions. The issue with the infusions is number one, they do it as a monotherapy. They're not addressing all the things that are causing the decline. They're not even looking for them. Number two, they're giving a high dose enough to clear that amyloid. And because of that, it's literally there's an antibody going in and ripping it out of the blood vessels, causing them to leak, which is why microhemorrhage is a very common concomitant. And unfortunately, there have been several deaths from this sort of therapy. So my hope is that in the long run, we'll again do a little bit like what Dr. Tanio was describing, get things going, improve people as much as you can, and then come in with micro doses of this just to gently move out the amyloid over time. Because yes, amyloid, when you have the oligomeric form, it's synaptotoxic. It does pull back on the synapses. It's part of your protective response. And so again, my hope would be that will change overall. As we are doing all this, we're getting new targets. Craig, have you had people coming to you who are either already on this or planning to do this? And what have you seen for outcomes?
Yes, we see a lot of people who have come in who are on Leqembi. And for the vast majority of them, when I've asked if they've had impact, there hasn't been much impact. They've said that there's been, they thought that, their neurologist said the decline is probably slower than it would have been otherwise, if you will, but
Yeah.
not the improvement in impact that we've seen in this study, which is visible and echoes what we see in real practice.
Yeah, it's a good point. There's a big difference between slowing decline without making people better versus actually making people better, going in the right direction. And the
Mhm.
trial and the published data on Leqembi had been that a 27% slowing. So instead of going like this, you go like that, but you don't
Mhm.
get better.
Yeah.
All right.
Um, you
Good.
mind if I add, there's one a little bit late. I know we're going to run out of time. There's I
Yeah.
think a really good question, which is,
Okay.
do you get treated by somebody, who's got experience versus, make do with resources closer to home? And I would just tell a couple things. I always try to approach this with principles because principles are more enduring, and then what you do later can always change year to year as better knowledge comes. I think the most important thing when people want to get treated is I think we're all pretty confident that if you get treated in the right manner, you should be able to hit the tipping point within 6 months, be able to
Yeah.
see improvement. And I think it's so important psychologically because if you don't see improvement, it's hard to have the faith to do all the work, necessary. And I've certainly seen people who have come in for a year or two and not had improvement, and they can be very discouraged. And so, I think the key is to get the right start in the beginning, and to get the right assessment. The biggest challenge that we I think we face is that how to deal with chronic infections and chronic
Yeah.
toxicants in the right way, and that's just an ongoing battle.
It's a great point. And, people, as I mentioned, people are now seeing continued improvements after 3, 4, 5 years. They're still getting better. The two most common problems I see when
Mhm.
people aren't getting better, number one, they wait way too late to start. They'll wait until, they're ready to go to assisted living or something like that. Please get in as early as possible. And that's again why these biomarkers have been helpful. And then two, they start and they do it halfway. They say, well, I'm
Yeah.
not going to do this part and I'm not going to do that part. And I think some of the great success that Dr. Tanio had, and Dr. Toops had, and Dr. Bergman had, and Dr. Hathaway and others have had, relates to the fact that they really had the people buy in. They really got them on. They identified the contributors, they treated them, and they really got people to buy in. And that's when you see these fantastic results. So I know we're
Yeah,
running
and
out of time here. Craig, thanks so much. It was great to have you on. Congratulations again on the absolutely spectacular results that you generated. And you're really helping to continue to make this better, 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 and getting best outcomes. That's what everyone is about. So great to have you on. What we'll do, there are a bunch of more questions. We will roll these in with the previous questions, and we'll get them answered on the follow-ups.
mhm. Very good, Dale. It was an honor to be on here and look forward to really getting this driving change and so that people can get access to this and get it covered by insurance over time.
Yeah, that's the way to go, and it's great to have you involved with your history in public health. I think you're going to be great at spearheading this and making this part of standard of care medicine, which is what it should be. So
All
thanks
right.
again.
All right. Take care.
All right, take care. Thanks. Bye-bye.
Bye bye.